Blackwell.
My lady, may I call the next witnesses, please? Professor Tom Shakespeare and Professor Nick Watson.
If you'd like to repeat after me, please. I do solemnly, sincerely and truly
I do solemnly, sincerely and truly
declare and affirm
declare and affirm
that the evidence I shall give
that the evidence I shall give
shall be the truth,
the whole truth, and nothing but the truth.
Thank you. Say it again, please.
I do solemnly, sincerely and truly declare and affirm that the evidence I shall give shall be the truth, the whole truth, and nothing but the truth.
Thank you.
Thank you.
Welcome back, professors.
Thank you.
Thank you for coming to help us again.
Thank you very much. Professors, in front of you, you should have copies of your joint report with the reference number INQ 000588216. Please, can you both confirm that that is the expert report that you have jointly provided for the purposes of the inquiry?
Yes, it is.
Yes.
Thank you. And that the facts stated within the report are true to the best of your knowledge and belief?
Yes.
And any opinions that you have stated in them, in the report, represent your true and complete professional opinions?
Yes, I do.
Thank you very much. May I also thank you for returning to the inquiry. For those who don't know you, I'm going to introduce you again. Professor Tom Shakespeare, you are a Professor of Disability Research at the London School of Hygiene and Tropical Medicine, and you have written extensively on disability, development and bioethics. And Professor Nick Watson, you are Chair of Disability Studies and Director of the Centre for Disability Research at the School of Social and Political Sciences at the University of Glasgow.
I retired in January. At the end
well,
of January,
congratulations.
so thank you. Yeah. So
Retirement-like, I
it's
wouldn't know.
magnificent. I recommend it.
And you have also written extensively on a range of disability issues, including disability in childhood, social care and social support for disabled people, for disabled young people in transition to adulthood, and from public service reform and poverty. Thank you very much. In introducing your report, it starts from a point of fact that the potential for disabled people and those with underlying health conditions were at a higher risk of harm from COVID-19, and that was well understood before the pandemic took full effect. Is that right?
Yes.
Correct.
Your report for this module explores the impact of the COVID-19 pandemic on inequalities experienced by disabled, clinically vulnerable and clinically extremely vulnerable people across the United Kingdom.
Yes.
Is that right? And it builds upon your previous report that was commissioned for Module 2.
Yes.
Professor Shakespeare, you have told us that not only were disabled and clinically vulnerable people often more susceptible to the COVID-19 virus, but both their pre-existing inequities and the social impact of pandemic control measures put them at an increased risk of harm.
Yes, it did. Yes, it did. Because our approach to disability is very much that people have conditions, maybe underlying conditions, but it's the social relations which render them very vulnerable. So it's a combination of both their intrinsic, as it were, vulnerability and the way that society is structured.
And that was known before the pandemic hit?
It was widely known, yes.
Right. Before we turn to the detail of your report, I just want to pause for a moment and acknowledge that both of you have indicated that in certain aspects of your expertise areas, there's data missing, that there is poor quality data and insufficient data. And I'd just like to ask you, please, Professor Watson, if you can help us with the areas in particular that are lacking.
I think that there's one area that's been particularly lacking is what's happened after the pandemic.
Right.
So how did there is some research on what happened to disabled people and clinically extremely vulnerable people during the pandemic, but what the impact of the measures that were taken during the pandemic have had on the long term around well-being and mental health, around employment, poverty, and so on. So there's that. And then I think the other area where there's a big shortage of data is around the intersection between disability and other protected characteristics around, for example, from people of black and ethnic minorities, or poverty, or gender, or others, and other sort of social characteristics.
Thank you. You tell us in your report that there are evidence gaps, for example, around violence and hate crime, gender-based violence, leisure activities, and also housing.
Yes, those were, we couldn't find anything on that, yeah.
And is there also data lacking in terms of those who were delineated as clinically vulnerable and clinically extremely vulnerable?
I think, yes, there's a shortage of data, and I mean, the issue around definitions of clinically vulnerable and clinically extremely vulnerable is a moving feast, because it was a new category that emerged during the pandemic, and so that there definitely aren't the well-established sort of markers that policy analysts could look to that there might be in disability. So, for example, there aren't easy markers around, say, people who are immunocompromised or so on. So there is that becomes very difficult, and there is a shortage of data specifically looking at clinically extremely vulnerable people.
Thank you. Well, staying with definitions for a moment, at paragraph 15 of your report, you use the term disability as that defined by the Equality Act of 2010, which says that a disabled person is defined as someone with a physical or mental impairment which has a substantial and long-term adverse effect on their ability to carry out normal day-to-day activities.
Yes.
And we heard yesterday from Professors Herrick and Majid about the definitions of clinically vulnerable and clinically extremely vulnerable people, and particularly from Professor Herrick that those definitions changed over the course of the pandemic, and indeed were different at times between all 4 nations of the UK and different across the world. Did that cause confusion for those that it affected?
I definitely. I think there was a lot of, people didn't know whether they were clinically vulnerable or not, or whether they were vulnerable to the pandemic or more vulnerable than others. And we had, in Scotland, different criteria used to England, and it did create problems.
And certainly that would be a problem for anybody, particularly if they had learning disability, because they would not understand. And so lots of folk who were maybe clinically extremely vulnerable, disabled people, would not know whether they were at risk if they went out their homes. So, yes, it was a lot of concern, a lot of uncertainty.
And I think also made worse by the digital exclusion that disabled people experience that we touched on in our last report.
Yes.
So there was a lack of ability to access the detailed information that certain people who had ability to use the digital media.
Thank you. The definition of disabled people is wide-ranging. It encapsulates a lot of people, doesn't it? And lots of those people will also have other difficulties. I want to ask you about the tailored response which local authorities should be perhaps considering in terms of, let's say, disabled women who need to relocate because of domestic abuse. Does there need to be consideration given to a flexible, portable package, really, for people who, for instance, fall into that category, and how should that be done?
Well, I think definitely, and particularly we know that rates of violence are higher for disabled people. Yes. We know that they're higher for women and men, and things like women's aid or any provision made by local authority needs to be accessible and understand that they may well have women and girls, men and women, men and boys who need their facilities. So they need to be accessible, and that's not just physical access, it's also understanding the groups of people who might use them.
Thank you. Of course, not all disabled people are clinically vulnerable, and not all clinically vulnerable people are disabled. And there is a wide spectrum of different types of issues which people have to grapple with in daily life. Professor Watson, Are people with learning disabilities more likely to have underlying health conditions that lead to more serious outcomes for pandemics such as COVID-19?
Yes, definitely. I think there's evidence from the Scottish Learning Disability Observatory that people with a learning disability at age 20 have the same number of comorbidities as somebody without a learning disability at age 50. So there's definite evidence that people with learning and whether those comorbidities are the result, are intrinsic to the individual's impairment, or some of them will be the result of social pressures, social barriers, poverty, and so on. And so that it varies between them, but I think it's undoubtedly the case that people with, according to MENCAP, 90% of people with a learning disability regularly experience a hate crime. So it's no wonder that creates comorbidities within people with a learning disability. So it's well established that people with learning disability have more underlying conditions than without.
Thank you. And drawing this together, your recommendation is that a better way of identifying people who are vulnerable and extremely vulnerable is a marker on GP records.
Yes. Yes.
Well, certainly people with learning disabilities, many of them would have markers on GP records. So we could see, our colleagues can see immediately whether they were disproportionately affected by these any of these measures, or indeed the underlying pandemic. Whereas lots of folk did not have markers.
Yes.
And therefore, how can you find out? There's no either NHS, social care, or government statistics that you can draw on. So it's more difficult.
Thank you. Let's turn, please, to look at the ultimate impact of COVID-19 and morbidity and mortality amongst disabled and clinically extremely vulnerable people. You tell us at paragraph 6 in your report that across each wave of the pandemic, both disabled women and disabled men had a higher rate of mortality than their non-disabled peers, and you rely upon the Office of National Statistics data for that. So let's look, please, at the tables that you have included in your report. The first table, which is at page 5, is the age standardised mortality rates for deaths involving COVID-19 for men. What are we looking at here?
Well, I think if you can see here, so the age standardised mortality rates are the rates where it would be standardised to what mortality rates should be without a disability.
Yes.
And so the more disabled an individual is, the higher their mortality ratio was. So, and ONS created different categories, limited a lot, limited a little, and limited less.
And we can see, sorry to interrupt you, we can see that down the left-hand column,
Yeah.
the disability status level.
Disability.
Yes.
And so at every level throughout the pandemic, disabled people across the range, whether they're limited a little or a lot, experienced higher mortality rates compared to non-disabled people.
Yes.
So there's 3 waves there, and I think ONS have wave 1, which was between the middle of January and to September in 2020. Wave 2 was September to June, and then wave 3 was the final stages. And all the way across, and you can see that standardised mortality ratio went up. So,
yes.
And it went up for non-disabled people as well.
Yeah.
But it went significantly up for disabled people. As you can see in the second wave, for example, it went up to 942
yes.
compared to 304 for non-disabled. It's 3 times the...
And remembering that this is not people who think they're disabled, it's people who have limitations as under the Act.
Yeah.
Thank you. We can take that down, please, and replace it with the table relating to women, please, which is at page 6. Thank you. And do we see a similar pattern there?
Yes.
Yeah. I think the the highest figure there is 670.
70, yeah.
As opposed to the non-disabled relevant figure for wave 2, which is 175.
Yes. So again, it's roughly a tripling again.
Yeah. Thank you very much. We can take that down, please. The impact of the pandemic on disabled and clinically vulnerable people's health and well-being. During the pandemic, you tell us at paragraph 22, disabled people were more likely than their non-disabled peers to experience high levels of loneliness, anxiety and depression, poor well-being, and their access to communication needs were neglected. And there was a survey that you refer to, carried out by the Glasgow Disability Alliance, reporting that 90% of the respondents were worried about their physical and mental health during the pandemic, and that similar findings were reported by Inclusion London, the Welsh Government, and Disability Action Northern Ireland.
Yes.
So similar patterns across the
yes.
UK. Why was that? Why were these issues being felt so keenly?
I think there were a number of reasons. You know, because disabled people they felt that they were more vulnerable, with good reason, that they were more vulnerable to the pandemic. But there was also issues that occurred. So, for example, things like the Coronavirus Act and the Do Not Attempt cardiopulmonary resuscitation.
Yes, we'll come to those in a moment.
We come on to, but those all helped to create that atmosphere of fear, and I think that there was that social care overnight. Social care disappeared. So daycare centres and day activities and so on just closed overnight, and so suddenly people were left feeling alone, and there was a social care didn't get the support that it needed. And I think that people were left in a vacuum, so there was that fear that emerged and that came through at that time. Thank you.
Well, you've mentioned it, so I'll deal with that now, if I may. The introduction of the Coronavirus Act. Mm-hmm. And that reduced many of the duties for local authorities to provide care and support for disabled people, didn't it? Allowing, for instance, temporary reductions or withdrawals of care and support, and suspension of assessments.
So, yeah, that allowed easements of the Care Act. So obviously people feared, rightly as Nicholas has stated, that their care would be withdrawn and they would not be able to get, for example, daycare or day centres or whatever.
Yeah, there was the fear that very few of the easements were actually used. We could find it, but it was the fact that it could happen that made people worried, and it was you know, I involved with Glasgow Disability Alliance. It was a major talking point amongst disabled people, was the fear of what was going to happen rather than what happened, and to their social care.
Sorry to interrupt, but the Coronavirus Act was actually better known than most pieces of legislation. My partner at the time was a doctor, and she carried a copy of the Coronavirus Act with her when she visited me, so that she could say, I'm in his support bubble, I'm allowed under the Act to visit him.
I suppose thereby demonstrating how people were really concerned not to break the provisions of the Act, but at the same time, it really invading their lives in a practical way. Yeah.
And I think at the time of the passing, there was a lot of concern expressed across the disabled people's organisations and organisations for disabled people who started to who expressed concern around the Coronavirus Act, and this became, I mean, it quite rightly expressed concern, which again created that sort of which sort of represented the concern that their communities were telling them.
Yes. In terms of social care and domiciliary social care, was there also a fear that the reductions that happened during the course of the pandemic were going to continue after the pandemic had lifted? I mean, were people in fear of not being able to socialise and really being left in limbo and in isolation?
Sorry.
Yeah, I think that across the pandemic and the response to the virus, there was a focus on health, but a neglect of the care sector. And when it was thought of, it was only thought of as people in care homes, older people in care homes, and not well thought of then. But actually, most older people and disabled people live in the community, and many of them do receive care workers, but they might be the same care workers who go on to work with lots of other people. And the provision of, for example, protective masking or whatever was less for people like that. We did a survey of people who received domiciliary care and their workers and found that they were neglected.
I think, Professor Watson, you also told us about a single mother living in Scotland who explained to you her fears and her isolation and how that had affected her.
When we were doing the research we did during the COVID pandemic, we interviewed, several parents of older disabled children whose young people went to a day service or a day centre of some form or other, and those were closed overnight, and care and support for their older child became their responsibility. Many of them had to furlough because they couldn't carry on working and manage the care of their child. And one of them told me she'd heard nothing from social services for over a year, and she was just left looking after her child. And I think that people felt this unsupported. They felt and we found things like in some of the work, we found that care workers who had normally been working with people with learning disabilities were shifted to work in a more health focused thing. So the emphasis was in the early stages of the pandemic was about saving the NHS and not about ensuring that social care was, or some form of level of social care continued. And I think, as Tom said, twice as there was some discussion of the care home sector, but twice as many disabled people receive care in the domiciliary care setting than in the care home setting.
And as for the levels of anxiety and depression that you found, there were similar findings, weren't there, for those defined as clinically extremely vulnerable. And I'd like to have a look, please, at the witness statement of Lara Wong from Clinically Vulnerable Families, who tells us about this. And it's INQ 0005657 at page 10 and paragraph 20. This relates to impact on mental health and well-being, as we've been discussing. And she says, the pandemic created sustained psychological pressures for clinically vulnerable people that went beyond the immediate threat of infection. Extended shielding, both formal and informal, repeated disruption to healthcare access, and prolonged exclusion from everyday activities meant that risk management became a constant feature of daily life. Many experienced the erosion of protective measures as a signal that their safety was no longer a public priority, amplifying feelings of isolation and abandonment. Their challenges were often compounded by pre-existing health conditions, which created new barriers to social connections and disrupted access to sources of emotional support. And does that accord with what you found in your research? Yes. Thank you. I'd just like to remain with Miss Wong's statement for a moment and scroll down to paragraph 23. Yesterday, during the evidence of Professors Herrick and Majid, we looked at the survey findings. The Clinically Vulnerable Families Group conducted a survey of their members, and they have provided us with the results of that, entitled Impact on Society Survey, and we'll look at that document in a moment. But their responses showed social isolation, increased infection risks, particularly in healthcare environments, depression and a sense of hopelessness, Particularly so, I just paused to confirm that when mitigations were lifted for some, that didn't necessarily accord with the lives that were being led by those who were clinically extremely vulnerable. And the so-called Freedom Day was anything but for those who were designated as suffering from those sorts of issues.
And their families.
And their families, yes, of course.
And I mean, I spoke to one family where the family had essentially split up, where the mother went to live with their disabled offspring and the father stayed with their two other non-disabled children so that they could keep them safe. You know, it created real trauma and real tension across the family.
And just to complete the list, grief and trauma were compounded by the circumstances such as being unable to visit dying relatives, and there were reports of loneliness. If we scroll down, please, to the following paragraph, paragraph 24. One thing that we didn't look at yesterday was the patterns over time. And we can see here that in the early shielding period, respondents to the survey cited extreme isolation, anxiety about the unknown risks of COVID-19, and distress over being unable to access routine medical care. The results of the survey also showed that in mid-2020 and early 2021, anxiety remained high despite some easing of restrictions due to continued vulnerability and concerns about inconsistent public compliance with safety measures. There was a slight decrease in anxiety following vaccinations, when the proportion reporting high anxiety decreased from 86.4% to 82.4%, and a further decrease was observed between July and October of 2021 and November of 2021 and January of 2022, although loneliness rose from 38.4% during the first lockdown to 54.4% by June of 2022, following the introduction of the Living with COVID policy. And does that pattern accord with what you found in your research?
Yeah, it certainly does. And we found people were very frightened of going out. They were frightened of non-masked people infecting them. They're frightened of going to healthcare facilities. And we need to remember that people who are clinically extremely vulnerable or disabled people may need healthcare facilities a lot more than non-disabled people. So in a normal course of events, they'd be more likely to go to hospital or rehabilitation or whatever, or GP. But now they felt that those very places were places they would get ill. So not surprisingly, they didn't go for needed support.
Did all of this lead to some disabled people and those designated as clinically extremely vulnerable feeling that their lives were being undervalued?
I think that, for example, I know this isn't relevant to this particular module, but I think when people see messages that there are deaths, but it's okay, they had underlying conditions, they feel devalued.
Mm-hmm.
Thank you. Please, could we display the article from the Office of National Statistics entitled Coronavirus and the Social Impacts on Disabled People in Great Britain? It's at INQ 000417407. We can see this is the front page. This is the document compiled by the Office of National Statistics. And please, could we go to page 2? And display the main points of this document and what the main findings were. We can see in February 2021, among people aged 16 years and over in Great Britain, a larger proportion of disabled people, 78%, than non-disabled people, 69%, said they were worried very or somewhat about the effect that the coronavirus, COVID-19, was having on their life. For disabled people, this proportion was lower than in September of 2020. Disabled people more often indicated coronavirus had affected their life than non-disabled people in ways such as their health, the figures are given there, access to healthcare for non-coronavirus related issues, well-being, and access to groceries, medication and essentials. Just pausing there, did you come across a difficulty for those who were shielding, either under direction or self-shielding, being able to access medical supplies, food, and such like.
Very much so. I think I've talked also about healthcare and people's greater reliance on healthcare and their fear of being in a healthcare environment. But also everybody at that stage, for example, if they had access to the internet, bought the shopping online. And people who always had to. So, for example, to take a personal case, I would always buy my shopping online because I cannot carry heavy bags. And I suddenly couldn't get any delivery for weeks because, of course, everybody wanted their shopping online. And I personally contacted my usual shop and said, I'm not included in extra vulnerable, extremely vulnerable, but I need this. And they put me on the list. But I had a sort of middle class. I felt this was outrageous. I couldn't get it, and therefore I complained, therefore I got it. Many people would not.
Yes.
And they would be excluded and have no remedy because they're not included in those categories.
Thank you. Reading on, feeling stressed or anxious, feeling bored and feeling worried about the future were the well-being concerns most frequently cited by both disabled and non-disabled people. Feeling bored has increasingly been reported by both disabled people with well-being concern since September 2020. Among people who indicated coronavirus affected their well-being, disabled people were more frequently than non-disabled people specified that the coronavirus was making their mental health worse. Again, is that something that accords with your research?
Definitely.
Absolutely.
Yeah.
People who already who are disabled people or have underlying conditions were very isolated, and as a result, we think of that, their mental health was worse. They were less likely to see family, let alone friends.
Yes.
And I think, having, again, those people with the withdrawal of social care, having to rely more on family members, it increased the idea that they felt more of a burden because they were having to ask family members to provide care that previously they had been able to get through the social care.
Thank you. And just moving briefly through the remaining bullet points, poorer well-being ratings, life satisfaction and happiness ratings were poorer, and they were disabled people were less optimistic than non-disabled people about life returning to normal. But at the bottom of this page and the final bullet point, we see positive sentiment towards the vaccine was high among both disabled and non-disabled people. Tell us about whether or not there was a change in the pattern of health and well-being once the vaccination system was up and running.
If people could get access to vaccination, and often disabled people would not get any priority about access to vaccination. And it took substantial evidential lobbying of the authorities before, for example, people with intellectual learning disability were placed in a higher priority. And it was the evidence that they're more likely to die from the virus, or more likely to contract the virus in the first place, was part of enabling them to get access to the vaccine that they need. It was a matter of life and death for them.
Because, I'm so sorry to interrupt you.
No, I stopped.
The vaccine programme, when it was first introduced, was initially prioritised by age, wasn't it?
Yes.
Yeah, and those with learning disability were particularly affected if they hadn't qualified to be on that list. But did the Joint Committee on Vaccination and Immunisation listen, and did they change the prioritisation?
Yes,
eventually. It took a lot of
evidence.
A lot of shouting to get them
Yes.
to listen would be.
And evidence, because, of course, they're public health people and they need evidence, and there wasn't any evidence except anecdotal or self-report, and people needed to gather the evidence. And the evidence of learning disability is, because there's a marker on the records, was there, whereas the evidence for other people is not there, because you just couldn't get the data. And, of course, they are rightly following science.
Yes, which I suppose is another argument for keeping those markers on GP
Yes.
records
Yeah.
for every sort of disability.
Yes, yes, it is.
Thank you. Can we take that down now and have a look at our Every Story Matters record for mental health and wellbeing, which is at INQ 000 659 895. And please could we go to page 23? Thank you. And I'm just going to read the stories from Skegness, which appears in the pink box here. At a listening event in Skegness, we visited a supported accommodation facility for disabled adults. We heard from those living in the facility, which provides residents with 24-hour care and support. They told us how the pandemic led to feelings of loneliness and despair, which were made worse by not being able to see their loved ones due to visiting restrictions. The way that COVID-19 cases were managed within the facility meant that if there was an outbreak, residents would have to stay in their rooms for days on end. This isolation from visitors, support staff and other residents often made their mental health much worse. A contributor told Every Story Matters, the main thing was I couldn't see my family. My mum lives 20 minutes down the road, but I couldn't keep in touch with family, and that was horrible. I like company, but when you can't see anyone, it's hard. And another contributor said, you couldn't see anyone, so you were on your own. Never saw a soul in isolation. There was nothing good about it at all. It had a devastating effect on everyone's health. You couldn't mix with anybody, no friendships. That's hard, isn't it? In the army, I had friends, but now, on your own, all of a sudden, it was very hard to be on my own. And I suppose it's worthy of note that even those who were living in a 24-hour care facility often were in isolation in their own rooms for long periods of time.
I remember being very struck by when we did our survey, our reports, qualitative reports from people, somebody saying there's only so much sleep you can have because you can't sleep all day for 24 hours. And they were very, very bored. They were very isolated and as a result, bored.
Thank you. Now, we've talked about the Coronavirus Act. I also want to talk, please, about do not attempt cardiopulmonary resuscitation notices. The inquiry has already heard evidence about these notices, but from your point of view, Professor Watson, could you just explain to my lady what the effect of those was when they were first brought into force and how perhaps it changed over time?
Well, I think initially NICE published a report, as I think we say in our report here. NICE published a report about a frailty score and DNACRs, and this created a fear. There was talk of sort of GPs sending out blanket letters to all their participants. My own wife got phoned up by the GP. She has asthma, to ask if she wanted this to be put on her records. And I think that this just again, coupled with the Coronavirus Act, it created this fear. And then, as Tom said, don't worry, the only people who are dying are disabled people. And then you get told your social care is going to be withdrawn, and then you're told, actually, if you do get sick, we're not going to attempt to make you better. And so this created a feeling of, and added to that, you've got that social isolation that you pointed to in the last document you showed. This whole feeling of we're not important, we're not part of the mainstream. They don't really care about us. So that added to the feelings of all of the. It's no wonder people felt anxious and felt lonely and had levels of depression and so on when those sorts of things were going on. And that there was just a real fear about, if I get sick, they're not going to make me better.
That a nice guideline which says that people who have complete dependence on personal care from whatever cause were the maximum score. Many disabled people and clinically extremely vulnerable people are completely dependent on care, but that doesn't mean anything for their ability to enjoy life or to participate in life. Many people work, like Lady Campbell. I know she was very observant. I know she was very concerned, and rightly, because when you apply a DNA CPR order to somebody, lots of people reported that their normal healthcare needs were also deprioritised. So it's not just if they were dying or in need of CPR, but also their general healthcare needs.
And the Care Quality Commission reviewed the DNA CPR policies, did they not? And found that there had been, in their words, unacceptable and inappropriate DNA CPRs being made at the start of the pandemic.
Yeah.
Strong words.
I mean, unusually strong for the Care Quality Commission to make, and I think those words make the point very clearly that it was the move was inappropriate. Not just inappropriate, beyond inappropriate.
Thank you.
We may just need, I'm sorry to interrupt, there's a perfectly valid point. I'm not attempting to undermine the point you made, but it's just that what I have heard in other modules about the use of these notices was there was a belief and a fear that there were blanket policies.
Yes.
But in fact, the evidence doesn't show there was a blanket policy, but it does show that there were instances of people like a GP not understanding that this shouldn't happen.
Yes.
Yes.
Thank you, my lady.
Thank you, correction. In the initial stages, it was not. It was felt to be a blanket policy. There's not necessarily evidence that it was. But so, for example, Professor Watson, his wife just has asthma. She's not disabled in any way that I can see. She's a wonderful woman, and she doesn't need support. But she was sent a DNA CPR letter by a GP.
Not a letter, a phone call.
A phone call. Sorry, I beg your pardon.
On that point, my lady, Professor Watson, at paragraph 60 in your report, you talk about discovering a GP in Wales who had sent out blanket communications to disabled and other patients. So it would appear that even if the intention was not to use it in that way, there was a misunderstanding at that level, and that's what was taking place. And I think you say that is but one example of many.
Yeah.
We've touched on social care, and you've told us that there was a real fear of social care duties being removed, and a lack of understanding, perhaps, of domiciliary social care and what that entailed and what that needed to include going through the pandemic. Was that a misunderstanding and a lack of consideration, really, across the United Kingdom, or was that just in one particular area?
I think it was across the United Kingdom. And I think, I mean, we make the point in the report that I point to the lack of involvement of either service users or their organisations at the stages of planning for the pandemic and for understanding how social care worked and the importance of social care to people's lives. And I think, for example, the early models on the spread of coronavirus didn't understand that a care worker would work with several disabled people in domiciliary. And that would have been pointed out. If SAGE had no representation from service users or their organisations in the early stages, and I think that it was, and so planning was being made. It was very top down. It was very, this is what we're going to do. There was no discussing with people what would be the implications if we did this.
Yes.
And I think if there'd been much greater involvement, we would have resolved a lot of these problems earlier on.
Thank you. And dealing with this issue in relation to those who were clinically vulnerable and clinically extremely vulnerable, please could we put on screen again the statement of Miss Wong? It's at INQ 000657970 at page 39. And let's look at paragraph 119, please. Many respondents to CVF's survey described substantial disruption in accessing social care services, often during critical periods when such support was most urgently needed. Across the UK, CVF members reported that services such as in-home care, personal assistance, respite, and other social support were significantly reduced or withdrawn altogether, frequently without replacement or meaningful communication. And if we move down to look at the quote that's included there from Alex, 45, in England, all support for my relative with severe mental illness disappeared overnight, and support had been very limited to start with. I was left with 24/7 unpaid caring responsibilities on top of my job, on top of my own health conditions. It was unmanageable and unbearable and has had a long-term impact on my health.
Yeah.
And I suppose that also goes back, Professor Watson, to what you were telling us about families and people having to choose who was going to look after the person that needed the most care, and that effectively splitting up the family.
Yeah. And I think those comments accord with our research and the work we've done down here, and things like short breaks and understandably congregate support had to be rethought. But what happened was, it wasn't that it was rethought, it was just withdrawn altogether. And there was no attempt to sort of say, well, families who benefited from short breaks, we won't give them short breaks. But there was no attempt to say, well, what can we do? Because the short breaks are there for a reason, to help the families.
Yes.
And there was no attempt to think, well, what can we do? Or how can we help people? And I think it affected both the families, but also very much the disabled people. And talking to people with learning disability, for example, these were the main social interaction, and then you withdraw that, and there was nothing there. And a lot of us were able to move on to Zoom to keep our family things, but where you had digital exclusion,
yes,
and so on, people didn't have that to draw back on. So people became very isolated, and it goes back to thinking about the anxiety. I mean, I remember talking to a young woman with learning disability as part of our research, and she'd become so anxious that she was washing herself every day with bleach and ended up in hospital with scars from the bleach. And these are with skin damage from the bleaching, and this is just a result of high anxiety building up and nobody to talk to, and nobody to say, actually, it's not a good idea to use, bleach as a soap, so it became a real. I think this, and again, like I said, we were missing these long-term effects of how that period of intense anxiety has played out post the pandemic for people with disabled people.
The inquiry has heard that there was a lot of confusion in terms of which health services might be accessible and which weren't, confusion with policy announcements and guidance, which were not always in accessible formats. I mean, you speak about those with learning difficulties, but also British Sign Language. They had to step up, I think, as one of the organisations to assist the government, didn't they?
Yeah.
So Nick can talk about the organisations, but the communication changed, and that obviously science was greatly expanding its understanding, but the communications were not always clear. And so, for example, lack of sign language on the main British UK announcements, but also we found that people with learning difficulties disabilities were often saying, what did that mean? Ring up their families, say, what should I do now? They just didn't know. It wasn't clear, and it changed.
The inquiry heard a significant amount of evidence yesterday about shielding, so I'm not going to take you to that, except to ask you about the information that you provide at paragraph 54 of your report, where you say one of the key problems with shielding appears to be the lack of consultation with those deemed vulnerable or the organisations that represent them. The response was not what was wanted, and the problem could have been avoided with more involvement of disabled people and their organisations. In the early stages of the pandemic, the category was based solely on clinical judgment, which, given the circumstances, was undesirable. But as the pandemic progressed, the communities became aware of the challenges that they faced, and there was thereafter little engagement with them. So, as a general point, has your research disclosed that there was very little negotiation, consultation, involvement, really, with those representing disabled people and clinically vulnerable people?
Yes, I think that would be the case, and I think assume we'll come on to it later, but this was where the third sector stepped up and provided that support in shielding, and I think that...
Well, let's move on to that, please, right. Professor Watson, because I know that you both want to pay tribute to the great supporting institutions who are the third sector, who stepped in, filled the gaps, gave advice, and really assisted during the course of the pandemic.
I think, without the third sector, and the way they stepped up, they're much fleeter of foot than the statutory agencies. They were much more able to change the way they, and also much closer to their communities. So they were able to know what was going on. And in the early stages of the pandemic, it was organisations like Glasgow Disability Alliance, Inclusion Scotland, Inclusion London,
Equal Lives,
who ran surveys of their members and brought the needs of how disabled people were being treated to public attention. And I think that this created they showed the plight of disabled people, but they were also changed the way they worked. Things like the Centre for Inclusive Living in Glasgow became a major provider of PPE because they recognised, so they went out and they sourced their own because they saw that the people living in their own homes weren't getting access to PPE. So they stepped in and provided this service where it wasn't being provided. They challenged the digital exclusion of disabled people. Part of it was because their funding streams were made. They were just told by the local authorities, spend the money as you want. And so money that they might have been used for running theatre groups or so on, they brought computers in, they sent laptops or pads or tablets to people. They ran classes to show people how to use them. They set up things, organisations, people with learning disability, set up chat rooms for disabled people, ran regular evenings, discos and so on for people to come together. And it was them they were the groups who held things together during this pandemic.
But both the existing groups and people come together to provide those facilities, which they lacked in the public, where they were not offered, so they provided themselves.
Thank you. At paragraph 66 of your report, you do say that there were regional differences in the way that governments worked with the third sector. You say that there's some evidence that governments in Scotland, Wales and Northern Ireland were more likely to work with disabled people's organisations than was the case in England. You give the example of the Minister for Health and Social Care in Scotland setting up a group and meeting regularly with the major disability organisations. But you also talk of there being a complaint, really, about how far that went, whether or not it was really effective, because Jim Elder Woodward from Inclusion Scotland has told you that a recurring theme was that Inclusion Scotland was increasingly presented with a near final draft policy and plan at meetings, and therefore, although there was an indication that there had been inclusion and consultation, in fact, in practical terms, it mattered very little.
It wasn't really what you'd call co-production. It was like this, telling people this is what we're going to do, what do you think, rather than how should we solve this problem.
Thank you. Now, before I turn to ask you about reflections on lessons learned and recommendations, there is one additional point, and I suppose it reflects upon a lack of data and a need for further research, but it's into black and ethnic minority disabled people and those who are clinically extremely vulnerable. And you deal with this at paragraphs 73 to 75 in the report. Is it right that there is a paucity of data and there needs to be more research into this area?
Yes. I think there's a lack of data. There's a general lack of data around ethnicity and disability, I'd say, and this was demonstrated during the pandemic.
For example, when we did a survey, we talked to interviews rather. We talked to lots of organisations, lots of individuals. We tried very hard to get organisations of black and minority ethnic people, and we failed. So that is partly our fault, but it's also partly that there weren't those to consult with.
Yeah. Thank you very much. I'm going to summarise, I hope accurately, and please you will tell me if there's anything that you would like to add to this, your reflections on lessons learned. You say at paragraph 77, the best outcomes were achieved when those affected by decisions were included in the planning process, and we've just confirmed that now. There was a lack of coordination between the various sectors, and that affected service delivery. There was a failure to take into account the needs of those who received domiciliary social care, and poor acknowledgement of the importance of the sector created significant problems. There was communication to disabled people and those who were clinically extremely vulnerable being of a poor level, and both groups were left feeling ignored and unsupported. You say the key role played by the third sector in helping disabled people and those who are clinically vulnerable and extremely vulnerable has to be acknowledged, and I hope that you've been given the opportunity to do just that. And as far as recommendations are concerned, you go on, starting at paragraph 82, to say this: further research is needed to explore the intersection between disability and other protected characteristics, geographical location, and socio-economic status. That social care needs to be seen as an equal partner to healthcare, and the importance of domiciliary care needs to be recognised. Better coordination is needed between statutory services and local and national governments and the third sector. Greater consultation with the third sector organisations is needed, together with co-production of services. There needs to be better communication and dialogue with disabled people and those who are clinically extremely vulnerable. There needs to be a better way of identifying people who are extremely vulnerable, for example, as we've discussed, a marker on GP records. And finally, there needs to be more secure funding for the third sector.
Yeah.
Is there anything that I've left out or anything that either of you would like to add?
No.
Professor Shakespeare, Professor Watson, thank you very much. There may be an additional
I think there are a couple
of
more
questions.
And I think the first one is from Mr. Wagner, who's over that way.
Can you hear me? Is that?
Yeah, now.
Yeah.
Do you've spoken quite a bit about the crossover between clinical vulnerability and disability and other factors. Would it be fair to say that the impact of the pandemic and the UK's response to it may have been quite different for disabled people and clinically vulnerable people, as in that obviously there's some crossover between the categories, but there were also some quite significant differences?
But they would, I would have thought that, as our evidence suggests, both groups would have been exposed to obviously the easements. Both groups would have been exposed to the Coronavirus Act and the guidelines in terms of social activity and so forth. So there is difference, but there's also they're all vulnerable. They felt they were vulnerable, whether truly or not, they felt they were vulnerable, and care was limited for definitely disabled people, but some clinically extremely vulnerable people would also have depended on certainly health, but social services, and they would not have had access to those.
And I think that evidence from Lucy Wong's report that Council reported on, where they talked about withdrawal of services, closure of respite centres and so on. Those are not terms that are just applied to people with who are clinically extremely vulnerable. Those are the experiences of what we would define as disabled people. And I think there's a problem that there was different experiences for different disabled people, and there's a danger. You know, disabled people are not a homogenous group. There's lots of different needs, and some disabled people were more vulnerable than other disabled people, and depending on the particular health needs and the particular health challenges they faced. So I think it's wrong to talk about these groups as if they're an homogenous group. There's differences that were created within it, and those experiences were different. And then the experiences of those people who relied heavily on social care, who may not have been extremely vulnerable to the virus, but were extremely vulnerable to changes in the delivery of social care, greatly impacted their lives and greatly impacted their well-being. So it's not, I think that you can look at differences and similarities, but the vulnerabilities that they faced were either vulnerabilities that were intrinsic to their condition, or they were vulnerabilities that were created by the response to the pandemic and the way that social care and healthcare and other things were organised. So I think that you should be looking at specific contexts for these.
May I just follow up with one question, my lady? Entirely understood the definitional issues, and there's lots of crossover. Would you also agree that there is a value in having a separate clinical vulnerability definition or category because it highlights a particular groups of people? For example, the immunocompromised, for whom there are very specific challenges, and I think you spoke quite a bit about the challenges of going to healthcare and facing dangerous environments because of poor air quality or spreading virus or whatever it would be. But would you agree that there is a value analytically in maintaining some kind of category of clinical vulnerability?
Certainly analytically, but it needs to be communicated extremely clearly who we're talking about.
Yeah.
Because even if people weren't clinically extremely vulnerable, they felt they might be. They felt they're in that group, even if they're not listed. So that risk or fear of, say, public environments or healthcare environments or whatever was common to all, even though perhaps not everybody was equally vulnerable.
Yeah. So, and I think that's something that clinically vulnerable families and Laura Wong, who you referred to, would agree with. Thank you.
Thank you, Mr. Wagner. And now I think it's Ms. Sojides, who's that way.
Grateful, my lady. Professors, can you hear me?
Yes.
Grateful. My name's Marina Surgeons. I represent the domestic abuse group, and I'll be asking a few questions. I want to start by addressing the impact on disabled people and those who are clinically vulnerable who experience domestic abuse. So your report recognises that the removal and disruption of social care during the pandemic had a disproportionate impact on disabled people and those who are clinically extremely vulnerable. That's at paragraph 30. And you further state, in some cases, disabled people were forced to return to their parents' homes, and that there also appeared to be an expectation by social services that families resume caring responsibilities for adult disabled relatives. For victim survivors of domestic abuse, this withdrawal of social care support increased their dependence on partners or family members for care, which in turn increased the potential for exploitation or abuse by perpetrators and created fewer opportunities to escape abuse. I wonder if in that context I can turn to the Disability People's Organisation's witness statement. If I can perhaps have it on screen, that would be most helpful, and in particular paragraph 140. It's on screen? Oh, grateful. And in particular, the sort of the halfway down that paragraph, which starts, what is particularly alarming? Do you see that, Professor?
Yes.
What is particularly alarming about the increased domestic abuse rates during the pandemic was that often abusive partners were not leaving the home due to lockdown policies, and therefore the opportunities for survivors to report abuse were severely limited. Instead, domestic abuse survivors were often trapped for long periods of time in the same house as the perpetrator. with that in mind, do you agree that this was a very real risk of reducing social care and placing caring obligations on family members was this? Would you agree with this statement?
Yes.
Yes, and I think that, you know, it's well known that disabled victims of domestic abuse, even outside a pandemic, have real problems reporting that domestic abuse, especially where it's the so-called mate crime that's going on. So I think that the pandemic increased the possibility increased the possibility of mate crime, but also it made it much harder to report, as it says here. So I think I wouldn't disagree with that at all. I think
I'm grateful.
Thank you very much indeed. That completes our questions for you. In fact, it completes the evidence for this week. Thank you both very much indeed. I'm very grateful. You were very helpful and clear last time and been so again, as I expected. And I'm sorry we've had to call on you more than once, but it's been really useful. So thank you very much.
Thank you for your work.
Thanks very much. Thanks.
And enjoy your retirement, Professor.
Thank you.
Thank you.
Don't
One
tell
day.
me what it's like. I don't.
One day.
That completes the evidence for this week.
It does.
Thank you very much indeed. I shall be chairing the hearings remotely next week.
Yes.
And I shall return to start sitting again at 10:30 on Monday the 23rd.
Thank you.
Thank you very much.